Good morning to everyone. So, dear colleagues, this lecture is dedicated on dense breast and automated breast ultrasound. And we heard a wonderful lecture from Professor Mundiker. So this was a very nice introduction. Here are my disclosures. And I would like also to show a slide from the study that was very recently published by Professor Tabar, where he showed in this study published in Cancer 2019 that women that are going under screening, organized screening, after 10 years, they have a lower chance of dying from breast cancer, 47% lower risk of dying from breast cancer compared to 79% for those women that do not attend screening. So undoubtedly, there is no conversation, no further discussion that screening, yes, indeed, it decreases the mortality rate. However, there is the rationale of the current breast cancer screening setting is that we still have high interval cancer rates. Also, the mortality rate from breast cancer remains high, and that supplemental screening beyond mammography has shown an incremental breast cancer detection. And the reason for this is that the detectability of breast cancer mammography varies according to breast composition. And when we have women with high density, with fibroglandular tissue, it absorbs the X-ray, therefore it appears white on mammography, and breast cancers that are not associated with microcalcifications will go undetected. Whereas in women that have fatty breasts, the X-ray is penetrated, and therefore a cancer will be very nicely identified. And the learning objectives of my talk is to present to you briefly the clinical implications of breast density, the measurements and risk that are and risk assessment models that we have now, the impact of supplemental screening with IBUS, and the future perspectives. And according to the BI-RADS, women with dense breasts are those women that have ACR, C, and D parenchyma, and comprises approximately 43% of women that are aged 40 to 74 years old. And we heard from Professor Mundiker that the implications of breast density concerns that these women have a high risk that varies about 2 to 6-fold risk of developing the disease, a decreased sensitivity of mammography, a higher interval cancer rate, and also a less reduction of the mortality rate. And not all women with high density have an increased risk of developing the disease, but mainly women that have ACR-D parenchyma are associated with a high risk that reaches up to 4 to 6%. Additionally, breast density has been recently incorporated as an independent risk factor for developing breast cancer. And this is what are the proposed explanations for the strong positive relation between breast density and cancer risk. Actually, there are different theories. One of them is that the epithelial cells counted are greater in dense tissue. Another is that the characteristics of the microenvironment is more conducive to carcinogenesis due to the production of certain growth hormones that stimulate cells to divide, and also that dense tissue functions as a biosensor of systematic factors that increase breast cancer risk. Due to these reasons, and due to the inter and intra-reader variation that we achieve with the BI-RADS density classification that varies between radiologists, more sophisticated for automated computer-based methods have been designed, have been developed, which are more objective, consistent, and reproducible tools, and we have some tools already commercially available. And recently, also in the updated version V8 Tyler QSIC, the breast density has been incorporated, as well as on the latest breast cancer surveillance consortium. And this is just a volumetric scorecard, how the measurement is automated, measured by Vourtsis, who have been working with Vourtsis, And another important clinical implication for breast density is the masking effect. Women that have dense breast have a high risk of having a cancer that is not identified. Also in the ACR, the masking effect has been described also for women with this type of pattern, just a localized area of region of density. And according to different publications, 1 every 3rd cancer is missed in women that have dense breast, while in the publication of Boyd, he has shown that women that have high density have a 17.8 higher chance of having a cancer that is missed. Some information about mortality rate. We do not have a lot of data on this, but according to this study, the Copperberg randomized control trial, it showed that women with dense breast tissue have a high rate of vitreous cancer rate due to the more advanced cancer diagnosis and also increased mortality rate, where the Dutch screening study showed that the mortality rate is reduced up to 41% in women with fatty breast, whereas in women with dense breast, look the difference, it is reduced only to 13%. And the density issue first started from Pam Smith, where she wrote a very nice book, 101 Things You Should Know About Breast Cancer. And later on, Nancy Capello was the first, was the lady that worked very hard, and the first legislation was passed in 2009 in Connecticut about breast density. And currently, 38 states mandate some level of density reported in the USA. So there is a pool of evidence undoubtedly that has shown that breast ultrasound, yes indeed, it increases the detection rate of breast cancers. More than 200,000 women have been evaluated with handheld, and has shown that in all these studies, there are many cancers that are detected additionally to mammography with breast ultrasound, and more importantly, those cancers are invasive cancers of small size. And according to these studies, there is an increase in the detection rate that varies between 1.8, which means translates approximately 2 to 4 or 5 cancers per 1,000 women screened. However, there are several barriers to implement traditional handheld breast ultrasound. It is time-consuming in countries like European countries. Also here in Greece, physicians were performing handheld by ourselves. And also there's a shortage of well-trained physicians. The performer is also the interpreter. There's a high operator variability and inconsistency in scanning technique. Also, physicians or sonographers need a thorough educational program, and we achieve to acquire small field of view images. And in women with very large and dense breasts, we feel less confident in scanning these patients. Therefore, a newer breast imaging modality has been developed, and hopefully in the near future, handheld breast ultrasound will be just used as a second look ultrasound, and automated breast ultrasound will be implemented and will replace handheld. And these are the supine scanners that have been developed. They're FDA approved, IBUS, automated breast, volume scanning, and trademarked by Siemens, and also the Invinia IBUS, automated breast ultrasound system, trademarked by GE. And IBUS provides multi-planar 3D reconstructed images that allow us to view the breast in 3 different orthogonal planes, and this is the coronal, the sagittal, and the transverse plane. This new imaging architecture of automated breast ultrasound provides automated scanning of a large portion of the breast with only one sweep. It houses a flexible hardware with software beamforming. It provides transmission of wide beams and gives us high frame rate to minimize noise, compound imaging, providing us optimized quality of images with high contrast, high resolution, and uniformity throughout the image. And just for you to understand, this is the focus beams which are installed in the handheld breast ultrasound, whereas in automated breast ultrasound, wide beams are used. A disposable membrane is used in order to create a uniform compression across the entire breast when we acquire the volumes. It also enables greater penetration to the convergent scan line geometry and improves the detail resolution and depth, and it also eliminates artifacts in the periphery. It minimizes the beam refraction. IBUS enables to reconstruct a lot of pictures together within a second to compute a full 3D volumes from one single strip. You see the scanning is performed automatically from inferiorly towards superiorly, and it provides a large footprint of field of view, approximately 15 by 17 by centimeters by 5 centimeters depth volumes with 2 millimeters thickness of each slice. Basically, for each breast, 3 volumes are obtained, the AP, the lateral, and the medial, and these 3 volumes are acquired in order to cover the denser part of the breast. And whenever we move larger breasts, as the case here, additional volumes are acquired in order not to exclude any part of the breast, and especially the inferior, this edge of the breast on the right and also on the left side that can be missed only with one volume, the upper outer. As with every imaging modality, we must follow a standardized review protocol, which includes the coronal and the transverse plane. Mainly, whenever we have diagnostic cases, we also review the sagittal plane. And how do cancers appear on IBUS? Professor Mudiger shows some cases. You can see here within the yellow circle, masses may appear as black holes or defects. They may be circular, they might be oval, or we might identify architectural distortions like this case. This is another case. They may be single or multiple. We'll have some workshops also today. So the major indication of IBUS is to supplement women with dense breasts that are having breast composition of AC, RC, and D. And I'll proceed with the literature review by showing just 2 important studies. One that was conducted in the USA, the SOMO Insight study. It included more than 15,000 women. It was published in Radiology in 2015. And this study showed that in women that additionally to mammography, IBUS was performed, there was an additional cancer detection, 1.9 cancers per 1,000 women screened. More than 90% of those cancers were invasive, and most of them were stage 1A or 1B at diagnosis, leading to the conclusion that the addition of IBUS to screening in women with dense breast increased the cancer detection yield of clinically important cancers. And from Europe, we have this study which was conducted in Sweden. We heard the introduction from Professor Mudiger. Here they evaluated almost 1,700 asymptomatic women. The results showed that there was a 57% relative increase in the detection rate of invasive breast cancers, and they also concluded there is a great impact, positive impact of IBUS when it is added to women with dense breast. Another study is the multi-reader study by Dr. Ginger, published AJR, where they also concluded that when IBUS was added to mammography, there was an increase in the detection, in the specificity, and there was an increase in the sensitivity, and the overall specificity remained actually the same, approximately the same. This is a screening mammogram in a woman with dense breast. You do not see anything, even in retrospect. There was a cancer located in the 9 o'clock position. You can see here the lesion on coronal and also on the transverse. This was a small invasive ductal carcinoma associated with DCIS, which was not observed even in retrospect. Another mammogram, a 53-year-old woman, she came in for screening. She had lumpectomy in the left breast. There is nothing visualized in mammography. However, you can all see these are the transverse slices. You can see the cancer that was an invasive, triple negative, invasive ductal carcinoma grade 3. So there are some technical important advancements of this new technology. It is operator dependent. It saves physicians time. We need less training. It provides large field of view. There is a lower variability, high reproducibility of images. Now batch reading is possible for screening. Also, we are having the chance to have virtual review of data without the patient's presence, while the coronal plane visualizes a large portion of the breast with only one image with volumetric acquisitions, just similar to mammography and MRI. Additionally, automated, you can see here by clicking the crosshair on a suspicious region, we always get automatically the distance from the nipple, also the location, and also the distance from the skin. And according to this study by Van Zelst, he showed that the coronal plane offers new diagnostic information and has added value compared to handheld. Few words about the recall rate. There is a lot of conversation. What about the recall rate with handheld or automated? So this study, the SOMO Insight by Dr. Bram, yes, indeed, we had, it has shown a high recall rate, 13%. However, according to the authors, this was due to the fact that this was a totally new screening modality. There was no experience at all from the radiologists that reviewed the mammograms. You can see the multi-reader study and as well the study from Sweden. The EASY study did not show any significant decrease in specificity, and there was a stable recall rate. And according to PERSCAN, also I would like to point this from our experience, combined reading is very important. Combined mammography along with breast ultrasound. Have one monitor and the workstation next to each other and combine the reading and also patient's clinical information. This is our study published in 2018 in European Radiology, where we compared IBUS versus handheld in almost 1,900 women, and they performed the same, but additionally to that, IBUS performed better in the detection of architectural distortions. We detected 3 radial scars and 1 small invasive lobular cancer. And I'll skip this because Professor Mudiger discussed this. So maybe there is a time, this is the time to improve the breast cancer screening and to transform into precision medicine approach where breast screening will be based on individual risk stratification and decisions will be made according to the age of the patient, stopping age, frequency, and modality of screening in order to maximize the early detection of important cancers and to minimize the harms through optimal research utilization. And we should look at some intermediate endpoints instead of waiting to have randomized controlled trials and to show a reduction in the mortality rate. There's technology advances very quickly. We cannot perform randomized trials because in 5 years technology goes ahead and those trials will have no value, where we can evaluate what do these imaging modalities offer regarding the node-negative invasive cancer detection and also the decrease of the interval cancer rate. And this is a flow chart that was published by Winterberg and me. And what could the future perspectives be? Actually, have more advances on equipment and also improvement on the interpretation. And IBUS number 2 will be launched in the USOBI meeting in October. And what are our expectations from this new technology? Actually, to decrease the time to transmit the acquired volumetric images, to have a software upgrade for faster image acquisition, and also to improve the archiving process so we can retrieve the images easier and have the possibility to compare with previous ones. Also, in order to improve interpretation, we must, CAT systems must be implemented in this automated breast ultrasound units in order to increase productivity will feel more confident and will achieve higher accuracy. And you can see here an example of the CubeView Cart, which is already commercially available for concurrent and FDA approved for concurrent reading, where an area of suspicion is highlighted, and then you can go back and you can review the area. There are two studies, one in AJR by Jiang, and also another study by Vourtsis, that have shown that this dedicated CAT system provides accuracy, and also it reduces the interpretation time by approximately 30 seconds to 1 minute. So this is also for screening very important. This is our little preliminary experience. We have detected 14 cancers that were obscured in mammography. However, only the 13 cancers were detected with CubeView Cart. The reason one cancer was not detected, it was only 3 millimeters of size, and according to the vendor, it detects cancers that are over 3 millimeters. And this is one of the cases. And this, another advance of, will be the performance of radiomics IBUS signature. We have already, we had a poster in last USOBI meeting in Athens, where we evaluated the performance of radiomics IBUS signature and the differentiation of benign from malignant breast lesions, and the area and the accuracy in the area under the curve was very high in these patients. So my take-home messages is that, yes, indeed, we are fortunate to live in a new era in the early detection of breast cancer. Breast density has been recognized that it restrains the sensitivity and specificity of mammography, and this is the reason why it has been incorporated into risk prediction models, and also we have already automated computer-based methods which provide objective, consistent, and reproducible breast density assessment. Also, supplemental screening with IBUS has shown an incremental increase in breast cancer detection. It overpassed the limitations of the traditional handheld. CAT systems are available. We spoke about CubeView Cart. However, further ongoing trials that will investigate the IBUS would possibly advance towards a new approach of breast cancer screening in these target group patients, and especially women with ACR deep parenchyma. I'm proud to present this slide, and I would like to thank you, Professor Mudiger, Professor Durante, also Professor Erken Eriba, for their contribution. This is the European Dense Breast Info Expansion, and these are the references that I used, and this is our publication and my recent review in diagnostic and interventional imaging. I would like to thank you all for your attention. Thank you so much.